Hello and welcome to this webinar entitled Latest Developments in Liver Health Diagnosis and Management, hosted by EMG Health and sponsored by Sanofi. I'm your moderator for today, Dr. Jonathan Sakia. And in today's session, you can expect an update on your knowledge on non-alcoholic fatty liver disease, or NAFLD, and its metabolic comorbidities, to learn about real-world aspects of NAFLD and its treatment, and finally, to hear more about the possibilities of treatment with essential phospholipids across the NAFLD continuum. We'll be hearing from three experts in the field: Professor Schattenberg, who's the director of the Metabolic Liver Research Program and the Clinical Liver Research Unit at the University Medical Center in Mainz, Germany. Professor Pavlov, who's the head of the Department of Therapy and head of the Center for Evidence-Based Medicine at Sachanov First Moscow State Medical University in Russia. And finally, Dr. Dajani, who is a consultant gastroenterologist and hepatologist at Asad Dajani Specialized Clinic, affiliated to Medcare and Saudi German Hospital in Sharjah, which is in the United Arab Emirates. After the presentations from our three expert speakers, we'll be conducting a live question and answer session. So please do enter your questions into the Q&A function, which can be found at the bottom of your screen throughout the speakers' presentations. So to begin, I'll hand over to our first speaker. Over to you, Professor Schattenberg.
Well, thank you, Professor Sakia, for this kind introduction. I'm really happy to be here today and be presenting during this webinar. My name is Jörn Schattenberg, and I'm the director of the Metabolic Liver Research Program at the University Medical Center in Mainz. And the topic of my talk today is non-alcoholic fatty liver disease and metabolic comorbidities, current understanding and perspectives. So these are my disclosures. In the next 22 minutes, I'm going to be talking to you about the potential relationship of metabolic comorbidities such as type 2 diabetes or obesity and the severity of non-alcoholic fatty liver disease. To me, it's important to be talking about and giving you a perspective on my view of the burden of NAFLD as a liver disease, the mortality that's related to that type of liver disease, and of course also the impairment in the quality of life that patients report. And I think there's some very exciting data I'm going to be able to share with you today. And then of course in the end, I'm going to briefly touch diagnostics. That's a whole webinar by itself, but I want to give you some highlights and potentially also highlight differences between the recommendations that are currently out there. So without further ado, I'm going to jump right into the topic. And when I talk about non-alcoholic fatty liver disease, I address a spectrum of diseases that ranges from a non-inflammatory subtype to, in the end-stage liver disease. So it's a broad field. And whenever we talk about non-alcoholic fatty liver disease, you have to address two aspects. One is the activity of the disease. And the activity is represented by the amount of ballooning and lobular inflammation. That leads to a certain amount of hepatocytes dying and regenerating. And that's very important, the concept that the activity of the disease is something that refers and in the end characterizes the presence or absence of NASH, non-alcoholic steatohepatitis. Now, inflammation over time and injury over time leads to regeneration. That's very useful if the injury stops at one point. If injury is ongoing, the disease progresses in stage, meaning you develop more severe fibrosis or in the end, even cirrhosis. So the concept, again, I'd like to highlight is that for NAFLD, it's very important to address the activity of the current disease. Is this NASH or not? And try to assess the stage of the disease. How far has the disease activity brought this patient towards end stage and cirrhosis? Overall, and I'm going to be showing you some German data here, the prevalence of non-alcoholic fatty liver disease is expected to increase until 2030. This is an estimation based on the prevalence of diabetes, and it shows you that the number of patients affected overall in this time frame increases from 18.4 to 20.9 million. And the worrisome aspects is that you see a doubling of the end stages, or the pre-cirrhotic F3 and the F4 space within that time frame. So clearly the disease burden is expected to increase. Now, what are the risk factors that contribute to non-alcoholic fatty liver disease? The development of progression of NAFLD is associated with a number of clinical risk factors that makes it somewhat easier or possible to identify patients. And I'm going to be showing you data on that. On this slide, you see summarized that age, gender, BMI, and also ethnicity are of concern when trying to address if a patient has non-alcoholic fatty liver disease or not. So with this, we're going to move into the risk stratification part of this talk. Personalization through clinical risk stratification is a very simple but very useful tool, because you do not need additional diagnostic tests, no blood, no imaging. If you have your patient in front of you in your office, you're able to do some risk stratification. And the data that undermines or underlines this risk stratification strategy is shown on this slide. You can see here both in the US NUHANS database, but also in the German tertiary care histological analysis, that the presence of diabetes has a high odds ratio for advanced fibrosis. So if you see a diabetic patient, this is a patient that you should be concerned about advanced fibrosis. Additional risk factors that are very clinically and easily to use are increased BMI, interestingly, the presence of arterial hypertension, and also age. So I think if you consider those 4 points, you have a very good picture of that you can generate a very good picture of the liver health of a potential patient. Now, to dig in a little more in depth into the data, this comes from the study that was shown on the right-hand side, so histological controlled study. We conducted this here at the University Medical Center in Mainz, and you'll see that we separated patients with early fibrosis stages based on histology, 0 till 2, and advanced non-cirrhotic fibrosis, F3. And here you see BMI is significantly higher in the advanced fibrosis population, the presence of diabetes, and some additional factors, for example, AST levels that tend to go up with more severe fibrosis. And I think, based on these very simple aspects, you can learn some and make some very simple assessments in the beginning. Now, of course, the patient with non-alcoholic fatty liver disease has additional metabolic comorbidities that are of concern because they increase the severity of NAFLD. And if you have more than 1, 2, 3, 4 risk factors, it has been shown that actually the severity increases as well. And obesity, we addressed increased blood pressure. I think pathophysiologically, that's very interesting. We haven't fully understood as of today yet how blood pressure actually affects liver fibrogenesis. In animal models, there's some early data related to that. You'll see that insulin resistance, of course, and lipid abnormalities are also very important for these patients. And the metabolic burden in patients with even mild non-alcoholic fatty liver disease in the absence of advanced fibrosis is significantly higher compared to patients with no non-alcoholic fatty liver disease. But it's also true the other way around. The inflamed and scarred liver affects other organs. So this is not a one-way street. And on the contrary, if you have inflammation in your liver, you get adverse effects with the cardiovascular system. Neurocognitive dysfunction is discussed. You do see cancer, and I'm going to show you data related to that. And very interesting associations that I'm not going to be able to discuss in depth is today, of course, also kidney function or the quality of diabetes control in these patients. So let me show you again some data that we generated here from Germany. This is an analysis in a large database, data from 7.3 million people that do have public health insurance in Germany. And within that large database, we identified and matched groups that do have NAFLD versus no NAFLD. And then we followed these patients from the index date over a time frame for 10 years and looked for the emergence, the incidence of cardiac heart disease, coronary heart disease, or cancer. And you'll see, while the baseline population is different in both cases, you'll still see that the NAFLD-coded patients do have a significantly higher incidence of both cardiovascular disease, but also cancer. Now, importantly, this is not an all or nothing aspect, but it is an independent contributor, meaning if you identify a patient with non-alcoholic fatty liver disease, his incident risk of coronary heart disease or cancer is increased compared to a case-matched patient without non-alcoholic fatty liver disease. And I think this points us towards the way that the identification of NAFLD, even in the absence of treatment, could be indicative of a patient population that performs less well. So here you can provide more expert management according to available treatments. So to follow up that way of thinking a little bit, I'm going to detail you some more recent findings, data that was presented in abstract format during the European liver meeting in 2020. Pike senior author Zubair Yunusi published a large analysis from the US death records. This is data that captures the causes of death or the causes of death on death certificates from tertiary care centers and is somewhat consistent and fairly consistent with population levels. The mortality records filed in 2017 were used to classify the cause of death in patients aged 20 years and more. And you see it's a respectable number, 2.7 million descendants included here. And then they looked actually at the number and quantified the causes of death in that population. And among the entire population, they observed 3.14% with chronic liver disease. Now, among all patients that died in that observation period, half of them had non-alcoholic fatty liver disease as an underlying chronic liver disease, while only a third had alcoholic liver disease and chronic hepatitis C, 17.7%. And now if you look in that subgroup with chronic liver disease, they observed that liver-related causes were the most common cause of death, while cardiovascular disease are only at 12%, and then they had non-hepatic cancer. I think this is a very interesting analysis and data set, somewhat contrary to what's been published previously, because in the literature, you'll find that cardiovascular causes are the main reason of death in patients with non-alcoholic fatty liver disease. Why could this be? Well, I think this addresses a very different database, but it's very robust data. And I think we'll have to see and wait for the full publication to be able to discuss in more detail how liver-related death over cardiovascular death in this population contributes to patients with non-alcoholic fatty liver disease. I think I summarized most on what's on this slide and gave you my thoughts on the previous slide. But again, I think something that I would like to highlight here is that they also had a relatively high number of extrahepatic cancers as a specific cause of death. And this fits very well with the recent publication I showed you earlier from Germany that we did in the large German database, where we observed an increased incidence of cancer in patients with living with chronic liver disease, in particular non-alcoholic fatty liver disease. So again, two sets of data from very large population-based trials looking at death certificates or insured patients that demonstrate a link with mortality, cancer-related cancer incidence in patients living with NAFLD. So in the next aspect, I'm going to be addressing disease burden. I'm going to again highlight two studies that were recently shown at the digital ILC. This one deals with patient-reported outcomes. A large number of participants were included, and the authors compared patients with NAFLD versus chronic viral hepatitis. And interestingly, NAFLD were more likely to be female compared to the chronic viral hepatitis population. And also you'll see some common risk factors in NAFLD that are not as prevalent in chronic viral hepatitis, for example, diabetes, hypertension, hyperlipidemia. Interestingly also is that NAFLD patients reported more fatigue compared to the chronic viral hepatitis patients, indicative of an increased disease burden when addressing quality of life here. On the other hand, the development of cirrhosis was less frequent, and I think chronic viral hepatitis, of course, a very common cause of end-stage liver disease. So a second analysis I'm going to show you here is, again, one that we led out of Germany, but also included patients from Spain, the UK, and Italy, so European registry, and patients that underwent liver biopsy were explored with regards to their quality of life using the CLDQ score, a comparable the same instrument that I was used in the previous study I showed you, and we actually tried to link the severity and the activity of the disease to outcomes. And on this slide, while it seems busy with a lot of graphs over it, you'll see that there are two findings that I'd like to highlight. One, females tend to report a lower quality of life when affected by non-alcoholic fatty liver disease compared to males. Now, that's not typical for non-alcoholic fatty liver disease. It seems to be true for most liver disease that females do express a higher disease burden here. And interestingly, and in line with what's been shown by the previous study, fatigue was the most prominent symptom that actually impairs quality of life. So patients with NAFLD express and experience a significant symptom burden, in particular around fatigue. And I think that's very important to remember when you do see and treat these patients. I think one aspect that has to be addressed too is that NAFLD is not on the top of the agenda of most health communities and policymakers, and that's why I intended to show you this study here, which is published and pioneered by Jeff Lazarus as a primary author. And they actually performed an analysis in 2019 and looked at NAFLD policies by the respective European countries. And needless to say that they observed that only a minority of countries did have specific recommendations or lifestyle programs or a clear referral pathway. So what does that study and analysis tell us? I think there is a lot of need to develop a roadmap and address patients' needs for patient pathways, help physicians to develop referral pathways in patients affected by non-alcoholic fatty liver disease in order to advance this field and be able to provide standard of care as suggested by guidelines. Now that brings us almost to the end of this talk, and I addressed guidelines that I think are important on the previous slide. And towards the end of the talk, I'm just going to show you that the screening and recommendations that are actually coming out of guidelines are not uniformly at this point. And this is an analysis that's going to be presented at the American Association of Study of the Liver Disease, the Liver Meeting Digital Experience Congress, which is going to be happening very soon, or just happened. So actually the screening guidelines, if you compare EASL, the UK guidelines, Asia Pacific recommendations, or ASLD, are not uniformly, when they address their recommendations, whether patients should be screened or not. And importantly, also the screening modalities are not uniformly across guidelines. Now, while these guidelines are a little older, and I think the refinement of guidelines is on its way, it's important to recognize that at this point, the recommendations are not uniformly in a lot of practice that is being performed is based on experts' opinion and available care in your specific region. So, dear colleagues, with that, I come to the end of this talk. Thank you for your interest, and I'd like to conclude that I showed you data that NAFLD severity is linked to metabolic comorbidities. It's easy to identify patients at risk of advanced liver disease if they're in your office based on their clinical risk profile, so with no need of intensive or cost-intensive additional treatments. I think NAFLD represents a considerative health burden, both reporting to liver-related mortality, but also extra hepatic morbidity, and of course, impaired quality of life. And to expedite the care for these patients, I think we need to refine patients' pathways and come forward with easy, applicable screening strategies. And the good news is there's a lot of initiatives on its way that are going to be addressing these shortcomings. And with that, I'd like to thank you for your attention.
Thank you, Professor Schatzenberg. My talk today is on the importance of real-world evidence in understanding the current NAFLD landscape, epoch and manpower studies results put into perspective. These are my disclosures of my conflict of interest. And warning objectives are to discuss the use of new non-invasive screening tool for diagnosis of NAFLD in high-risk patient populations. Second, to review recent clinical evidence supporting the use of essential phospholipids in the treatment of non-alcoholic fatty liver disease. And third, to present highlights from manpower real-world study of essential phospholipids treatment in non-alcoholic fatty liver disease patients with cardiometabolic comorbidities. Epoch is a retrospective analytic study, real-world evidence study. Rationale is to find people with non-alcoholic fatty liver disease, which is underdiagnosed in the Russian population, as well as in other countries. To screening relies on diagnostic imaging, especially ultrasound, which may not be widely available in many countries. And in the diagnosis, of course, are used some non-invasive markers, which are not validated yet, such as hepatic steatosis index, which we used. Study design, it is, as I mentioned, retrospective analytic study of data received during the 3 population study done in Russia, especially direct one study, cross-sectional multicentral study in Russian patients with non-alcoholic fatty liver disease, in which we included 297 patients. The objective is to develop a full non-invasive diagnostic test for non-alcoholic fatty liver disease. And the prevalence of non-alcoholic fatty liver disease in the Russian population was 42%, age up to 35 years, in presence of diabetes 2 and waist to height ratio more than 0.54. The non-invasive scale as the index accurately identifies steatosis in 91.4% or at time accurately ruled out steatosis and 93.8% of people. Based on the analysis of data received during our population study, we proposed this ST index, a new non-invasive tool, which is very handy, very simple to be done in the clinical practice by the general practitioner and gastroenterologist. It includes age, diabetes 2, and waist to height ratio. Next is the evidence for essential phospholipids use in non-alcoholic fatty liver disease. We proposed, based on analysis of our data, we proposed the evidence-based matrix of non-alcoholic fatty liver disease pharmacotherapy based on two parameters: level of existing scientific evidence and the likelihood of improvement of clinical meaningful parameters. And here you can see at the upper right corner the essential phospholipids, which demonstrate effectiveness in steatosis in non-alcoholic fatty liver disease from 5 randomized clinical trials. These data about the use of all kinds of hepatoprotectors are published in Russia and Russian language. If you speak about the clinical effects of essential phospholipid in steatosis, as I mentioned, ultrasound diagnosis is widely used. Two groups of patients, 43 people in each group. One group metformin plus essential for essentially 41,800 milligrams per day for 6 months. The second group received metformin for 6 weeks. And here the results are. We have improvement in state of steatosis in non-alcoholic fatty liver treated with essential phospholipids plus metformin in 86% of patients, compared to the control group, in which we have improvement of 65% of patients in this group. If you compare the data from ultrasound investigation of ultrasound diagnosis of hepatic steatosis, you can see the results of a meta-analysis including 45 studies, in which we have a comparative study between morphological data and data from ultrasound investigations, and the main sensitivity of ultrasound for diagnosis of liver steatosis was 85% and specificity of 94%. Real-world evidence highlights from Manpower study. This is the study design of Manpower study, observational study, 6 federal districts, 174 medical sites, patient recruited from September 2015 to September 2016, 2,843 adults participants included. Primary endpoints were to evaluate the effectiveness of essential phospholipids adjuvanting therapy in improvement liver function test of non-alcoholic fatty liver disease in Russian patient, and secondary endpoints to evaluate of changes in the lipid profile from baseline to weeks 12 and 24 in patients receiving essential phospholipids alone or phospholipids in addition to lipid-lowering agents. Inclusion criteria was non-alcoholic fatty liver disease, comorbidities such as obesity, diabetes 2, hyperlipidemia, hypertension, adjunctive essential phospholipid therapy, 1,800 milligram per day, and exclusion criteria, other etiological factor for chronic liver disease were excluded, and other hepatoprotectors. These are our publications for the last 2 years, including data from this study. If you speak about the comorbidity in this population study, including once again 2,843 patients, 80% of patients were with comorbidity obesity, 75% hypercholesterolemia, 57% arterial hypertension, and 16.8% diabetes 2. essential phospholipids in dose of 1,800 milligram per day were prescribed for 6 months, and adherence to treatment constituted 90.5%. In this slide, here you can see that steatosis of the liver was diagnosed by ultrasound in 75% of patients. Adherence to diet and physical activities was much lower than the adherence to essential phospholipids treatment. Adherence to diet and was about 13.8%. These slides demonstrate the results of essential phospholipid on steatosis demonstrated by different variables included during the ultrasound investigation, such as diffuse liver hyperechogenicity, distal echo signal attenuation, heterogeneous liver structure, indistinct vascular pattern. All these variables demonstrated positive dynamic at week 12 and week 24 of treatment with essential phospholipids. Essential phospholipids improved liver echogenicity in all comorbidities group. You can see here different groups of patients with hypertension, overweight, diabetes 2, and high cholesterol. And the improvement in this parameter in all this group was from 67 to 69% of patients. Essential phospholipid improve liver echogenicity regardless of the number of comorbidity. And here you can see the different groups with one comorbidity to 4 comorbidities. And once again, in all group, essentially administration demonstrated improvement in the diffuse liver hyperechogenicity from 67 to 69% of patients. These are the results reflecting the improvement in liver enzymes from week 12 to week 24. We can see here the normalization of levels of ALT, AST, and GGT as markers of biochemical activity of NAFLD. Essential phospholipids improved liver function tests in all comorbidities group, and here you can see the changes in the liver function tests at week 24 according to comorbidity. Patients with hypertension, obese people, diabetes 2, and high cholesterol. One additional benefit of essential phospholipids administration on lipid profile were demonstrated, and here you can see the impact of treatment with essential phospholipids. Yellow is a group with essential phospholipids plus statins, and brown is the impact of essential phospholipids in decreasing in improving the markers of cholesterol profile. As a conclusion, the ST index represents a new non-invasive screening tool to detect steatosis based on the real-world data. In non-alcoholic fatty liver patients, treatment with essential phospholipids is associated with clinical improvements in the ultrasound characteristics, including the reversal of steatosis. Recent real-world evidence demonstrates a significant reduction in the severity of steatosis with essential phospholipid treatments in more than 80% of patients with cardiometabolic comorbidities due to their anti-steatotic mechanism of action. Thank you for your attention.
Good afternoon, ladies and gentlemen. I would like to thank the previous speakers for their excellent presentation, Professor Schattenberg and Professor Pavlov. I would like also to extend my regards to Dr. Pavlov, who has presented me to give this lecture. I'm going to talk about the role of essential phospholipids in the non-alcoholic fatty liver disease continuum. These are my disclosures. And the learning objectives of my talk would be to describe the current treatment strategies utilized for patients with NAFLD, to understand the place and expectations of hepatoprotective medications in the NAFLD treatment landscape, and to review recent evidence supporting the use of EPL as supportive treatment for NAFLD and comorbid conditions. Actually, I'd like to remind you that there is no specific treatment for NAFLD at the time being. Therapeutic strategies are currently based on treating associated comorbid diseases with medicines that may have a positive impact on the liver. So, the treatment would start with lifestyle modification, that's diet and exercise, then medicines that would target the comorbid diseases like diabetes, hyperlipidemia, and obesity. And here we suggest that there should be a role for liver hepatoprotective agents. And here we have the EPL, silymarin, and others that have been claimed to offer support to the liver when used. Liver-directed pharmacotherapy is a recent thing that would be available soon and may be of help in the future, not to forget the role of bariatric surgery, and finally, to manage complications whenever the patient comes to the end of the disease and we get into liver cirrhosis with all its complications. A moderate calorie restriction leading to a loss of weight of about 10% would lead to significant improvement of NASH histology. And physical activity, whether aerobic or anaerobic, resistant or stretching exercises, would all lead to a decrease in insulin resistance, which is one of the important factors leading to NAFLD. At least 240 minutes a week of exercise should be performed by these patients. Then we have the patients, the medicines that could target diabetes, hyperlipidemia, and obesity. Metformin, pioglitazone, SGLT2, and GLP-1 agonists, for example, are used in the diabetics, and all of these might have a good impact on the liver. Statins, ezetimibe, and pemafibrate, which are used for the treatment of hyperlipidemias, may also have a good impact on the liver. And for obesity, we have orlistat, liraglutide, and semaglutide, all of which are important. Hepatoprotection is another factor that we have to focus on. Hepatoprotection could be by providing antioxidation and supporting the mitochondria and cell membrane. For these, EPL is one of the very important agents that have offered all these effects, but not to forget vitamin E and silymarin, which could be at a lesser degree helpful. The liver-directed pharmacotherapies are drugs that has been ongoing on research for the past 4 years. Some of them has passed phase 3 study, and some others are still awaited. They are not yet available on all markets. Only few of them are, and they are very expensive and include elafibranor, the obeticholic acid, cenecrivarec, and selonsertib. Finally, bariatric surgery, whether restrictive or malabsorptive, would improve histology in about 80% of the patients. Talking about liver protection, why is that needed? First of all, let me tell you that whatever is the cause of the damage to the liver, what happens is that there is a damage to the cell membrane, to the mitochondria, and to the endoplasmic reticulum. The cell membrane will have reduced phospholipid levels, altered phospholipid composition, and decreased fluidity, whereas the mitochondria will become really swollen and it will have detachment, reduction crest granules, and deposition of high-density crystalline substances in some granules. The endoplasmic reticulum will lose its capability of producing proteins or detoxifying the material that would harm the liver at the same time. Now, the treatments available for NAFLD aim at directly or indirectly target the pathogenic aspects of the disease, which is hoped to stop further damage and to stabilize the hepatocyte, thus allowing for self-repair. Hepatoprotectors, on the other hand, would target the organ damage, the end organ damage, the cell membrane, the mitochondria, and organelles. So adding both together would be a real good achievement in order to reach with the liver to a safe situation. Why do we need hepatoprotectors? Simply because our livers are endowed with overloads of many potentially harmful agents. Processed, preserved, refrigerated, and other cooked material could be of damage to the liver. Poor nutrition, injudicious exposure to antibiotics, chemotherapeutics, and over-the-counter medications. The work overload, physical and mental stress are other factors. Excessive indulgence in alcohol intake, energy drink intake, and smoking. And finally, some environmental factors would be important. The hepatoprotectors should support the liver by activating the phospholipid-dependent enzymes, by promoting favorable metabolic effects, improving detoxification function, decreasing fatty infiltration of the hepatocytes, inhibiting or correcting fibrogenic processes, inhibiting apoptosis, and of course, they should have some anti-inflammatory and antioxidant properties. Why EPL? What evidence do we have for that? We learned a lot from animal models, which have shown clearly that animals who have been fed with high-fat diet would have significant improvement of steatosis due to increased triglyceride oxidation, decreased synthesis, and increased lipoprotein secretion. So by doing so, it would lead to a reduction of the steatosis in the animals that has been tested. One of the earliest studies that have been done by Concierge and his colleagues was a double-blind placebo-controlled trial in patients with non-alcoholic fatty liver disease. And they have shown that EPL improved steatosis as compared to placebo according to biopsy results. Another study, which was a prospective randomized controlled parallel group study of EPL in people with diabetes from China, has shown that adding EPL to the treatment would lead to significant reduction of the transaminases, blood sugar, and improve the lipid panel. Triglycerides and LDL will be reduced and HDL will be increased when EPL is added to the treatment. Another randomized prospective blinded clinical trial to evaluate the efficacy of EPL in patients with NASH, and type 2 diabetes mellitus by SAS from Russia have shown that there is significant improvement in ALT, AST, gamma GT. And in addition to that, there was significant improvement in the ultrasonography of the patients who were treated with EPL besides the diabetic medications. Another randomized open-label study to evaluate EPL in the diabetic and hyperlipidemic patient was done by us in the United Arab Emirates and has shown significant clinical improvement, reduction in transaminases, and improvement in sonographic and fibroscan findings in the people who were having EPL in their treatment. Other studies have shown that when EPL is added to other agents, it improves very much these agents. For example, metformin was claimed to have some good effect on the liver, but when EPL is added to metformin and was compared to metformin alone, it has shown that there was a significant improvement in triglycerides and LDL levels in the EPL treated groups, although ultrasound findings were the same in both groups. Probiotics have gained interest over the past few years, and it was shown that EPL, when added to probiotics, would have a greater reduction of ALT, AST, and improvement in lipid profiles in the EPL and probiotic group patients as compared to the patients who were treated with EPL alone. but the improvement was in both groups. However, the addition of probiotics increased very much the case. Arvind looked into EPL versus UDCA in diabetic obese patients, and he has found that there was a greater and consistent improvement of ALT, AST, alkaline phosphatase, and a trend towards a significant improvement in sonographic findings in the patients who were treated with EPL. When EPL was added to Salimarin and was compared with EPL and glutathione as a control group, both of the groups have significant improvements, but the ones of EPL and Salimarin was much higher than the control group. Finally, when compared with vitamins, EPL demonstrated better outcomes for all parameters evaluated. That had led us to do a very important systemic review and network meta-analysis to look for the effect of adding EPL for patients of NAFLD associated with metabolic disease. This was published earlier this month in the World Journal of Clinical Cases, and it's available for everybody to read. We looked into the cases of NAFLD and EPL and could identify 2,732 cases based on title and abstract after removing the duplicates from the work. And then this was done through a rigorous search through the PubMed, Embase, Cochrane Library, and other sources. Then we have excluded about 2,570 because they do not fit into the purpose of the analysis from the beginning, ending up with 162 full text articles, which were assessed for eligibility, and out of these, 58 were found to have evidence synthesis. We used about 10 of them for the network meta-analysis. The objective was to evaluate the efficacy of EPL in patients with NAFLD associated with metabolic syndrome, obesity, and/or diabetes. And we followed the PICO framework. For the analysis itself, participants were adults with NAFLD and metabolic syndrome. Interventions were any of the following: drugs as a mono or combination therapy, EPL, UDCA, Silimarin, vitamin E, pioglitazone, etc. The comparators were any, and the outcomes was at least one of the following: the efficacy and effectiveness outcomes on transaminases, on lipid profile, on fibrosis, on the HOMA-IR index, on the disease response and severity as assessed by ultrasonography. These were, in fact, looked at like this. We had 48 studies investigating oral EPL. Out of them, 19 were dedicated to our work. These came from China, Russia, UAE, India, and Poland. And these are the different studies that we have used in our analysis. As you can see here, most of them were prospective open label studies, and the outcome will be discussed very shortly. The core analysis categories was spread into 3 categories: the direct meta-analysis, the indirect meta-analysis, and the cohort meta-analysis. The direct meta-analysis included patients who had EPL and antidiabetics versus antidiabetic therapy alone. The endpoints were, as mentioned earlier, liver function tests, lipid levels, and recovery and disease severity measured by ultrasonography. The indirect meta-analysis looked at EPL versus traditional Chinese medicines. 2 studies were identified for that, and the same endpoints were looked at. In the cohort meta-analysis, EPL data from randomized controlled trials, 5 studies were identified, and the endpoints were exactly the same as others. Now, analyzing the data in the direct meta-analysis group, you would find that the reduction in ALT, in triglycerides, and in total cholesterol was significantly higher in the patients who were taking EPL and antidiabetic therapy as compared to the patients who were taking antidiabetic therapy alone, as shown in the graph here. Again, the disease recovery was more remarkable with the patients who were having EPL. It was more in favor of EPL, as you can see here. And at the same time, the disease, the improvement was quite remarkable for the EPL group, either partial or significant improvement. And the overall improvement was also in favor of EPL added to the antidiabetic therapy, whereas no change was in the case of the patients who were treated with antidiabetic therapy alone. The severity of the disease was also evaluated, and you can see here that the very severe cases, the moderately severe cases, has shown significant response to EPL added to antidiabetic therapy. The same was not noted in the mild cases, but the overall was in favor of adding EPL to the antidiabetic therapy. Now, sonography has shown also a significant improvement for all the patients who were treated with EPL and antidiabetics. And in very few studies which looked at AST, there was also a significant response in favor of EPL added to the antidiabetic therapy. Now, moving to the indirect meta-analysis, which, as I mentioned earlier, was looking into traditional Chinese medication, certain herbal concoctions, as compared to the EPL added to the same. And you will notice that when EPL is added, there was a significant improvement in response, in reduction of ALT, and improvement of triglyceride levels. So EPL also helps in this situation. The disease response, whether partial or complete improvement, was also in favor of adding EPL to the traditional Chinese medications as compared to the TCMs alone. Moving to the cohort meta-analysis, and here these are representing the outcomes in the randomized controlled trials. And you will notice that the drop in ALT and AST was significantly better when EPL was added to the treatment given for the patients. There was also significant clinical improvement in these patients altogether. For the non-randomized controlled trials, which were in the cohort meta-analysis, you will notice the same trend, that ALT and AST has significant reduction when EPL is added to the treatment. And so is the case with the clinical improvement, where you see that the patients have improved significantly with the addition of EPL to the regimen of therapy. So let me summarize this by showing you this slide, which addresses the issue of the disease severity and the disease response. And as I have mentioned earlier, that patients with very high and severe disease or moderate disease did very well when EPL was added. And I mentioned earlier that the milder forms, for reasons that we do not know, they did not show the same. But the overall was in favor of adding EPL to the treatment. The disease response, whether it is partial or complete, was in favor of adding EPL to the treatment again. Let me just put things into proper order. Now, this is the spectrum of NAFLD, as you heard earlier. The steatosis, the steatohepatitis, and the cirrhosis, which is to become now the MAFLD, as we call it, D, which is the metabolic associated liver disease. We don't have yet the full description of this disorder, but until then, we are going to use the same old spectrum. And I'm going to show you what should we do for each group of these patients. For all, we have to revert to lifestyle modification, diet and exercise. We should encourage the patient, as I mentioned earlier, to do a minimum of 240 minutes in a week in order to achieve good exercise level performance. Of course, cirrhotics have to have certain limitations because of the severity of their illness. Then comes the hepatoprotective agents. And we have the recommended medications for this. EPL vitamin E, and silymarin. We don't have any evidence base for the use of UDCA and S-adenosyl methionine. They have uncertain effects, and therefore their use is not very much recommended by many authorities and institutions. Treatment of the comorbid disease is helpful. For the diabetics, metformin, pioglitazone, liraglutide, and SGLT2 agents, all of them would help very much in the steatosis and steatohepatitis. But there is insufficient data to tell us whether they are going to improve cirrhosis or not. In the hyperlipidemia patients, statins, ezetimibe, and pemafibrate also may help improving steatosis and steatohepatitis, but there is still no sufficient data for their effect on liver cirrhosis. The newly introduced agents, or to be introduced agents, would be used only in the NASH setup. They have no role in steatosis or in liver cirrhosis because simply we don't have any data. But it's not justified to use these agents at a very high expense for the treatment of steatosis, which could be controlled by the other medications, or for the treatment of cirrhosis. Bariatric surgery could be of help in the obese patient with steatosis or steatohepatitis, but it definitely has no role whatsoever and should not be done when the patient has already progressed into liver cirrhosis. To conclude, ladies and gentlemen, currently used NAFLD treatments aim to prevent further hepatocyte damage and to promote self-repair, whereas hepatoprotectors may directly improve cellular structures of the liver. So they are, in fact, cofactors working together. Adjunctive therapy with hepatoprotective treatments, therefore, may offer a reliable therapeutic strategy for NAFLD. Evidence from recent meta-analyses support the role of EPL in the treatment of steatosis, steatohepatitis, when present with other comorbid conditions. I would like to thank you for your attention. I would like to thank you all for your attention over the past 3 talks, and I would like to thank my co-speakers, Professor Schattenberg, Professor Pavlov, for their very interesting topics that they have presented. Now, the webinar is open for discussion, and while we are getting your questions, let me first put forward a question to Professor Schattenberg. What is your experience of FibroScan as a screening test for non-alcoholic fatty liver disease?
So thank you, Professor Dajani. I believe your question was my experience on the transient elastography FibroScan to screen. And I think it's a very valuable tool to rule out advanced fibrosis. So you can use it point of care in your patient in your office to take patients that are in earlier stages. That's where the real strength of this technology comes in. The sensitivity is a little lower, so to actually rule in patients, there's a certain gray zone, but it helps you to identify patients with relevant disease stages. So in my hands, it's been proven very useful to identify patients at increased fibrosis stage, and that's where I use it most.
Right. We also use it for evaluation or quantification of fat through the CAP technique, the continued attenuation parameter, whether doing it by the traditional equipment or by the recently introduced ultrasound-guided attenuation parameter. It helps in identifying that more.
I agree.
Right?
I agree. I think the longitudinal measurements, repeated measurements, haven't been performed as routinely. It's been more used cross-sectionally, but I think we see emerging data also from yourself to better understand how changes in CAP over time in one patient could translate into more or less liver health.
Right. Another question probably to Professor Pavlov. How prevalent is hepatitis B or C together with NAFLD?
Thank you, Professor Bajani, for this question. If you speak about Russian population, our data, we have about 3.5%, because we speak about the observational studies in which the prevalence of NAFLD is about 35%, and the prevalence of Hep C is about 3.5%, and is 1.5. So we have a small part in this group of patients with chronic hepatitis, viral hepatitis. If you speak about our 3 observational study done in Russia, it's Direct 1, Direct 2, and Manpower. So we have a small proportion of patients in this study which were diagnosed by this chronic hepatitis, viral hepatitis, and this patient, of course, were excluded from the analysis of patients with NAFLD, if you speak about the data which I presented.
Yeah, but there is no correlation between the viral hepatitis and the NAFLD. It's an added factor rather than a sort of a cofactor contributing more to the disease, right?
Yeah, correct. Here, if you speak about the cofactors, I always advise to keep in mind the alcohol intake in this group of patients. So it may be relevant if you speak about the cofactors of contributing to the steatosis of liver in this group of patients. Of course, accelerating process of fibrosis and so on.
Thank you very much. Professor Schattenberg, a question asking about the timing of development of NASH from NAFL.
Yes, thank you. Very difficult question, I would say. I see very diverse patient trajectories. I think we do have better data with regards to the progression of fibrosis stage. In general, it's accepted that it's a slowly progressive disease. Fibrosis progresses over a couple of years. However, there are certain patient populations, mostly that have a lot of accumulated risk factors, that progress very rapidly. How long do you have fatty liver before you progress to NASH? I'm not sure we exactly know that yet. The development of additional diabetes, hyperlipidemia, obesity is for certain a trigger. And I think in this environment, patients tend to progress faster. On the other hand, you have diabetic patients that do not exhibit NASH. So it's a little bit difficult to tell because we rarely see longitudinal biopsy-controlled studies that are needed. With emerging better biomarkers, we'll learn more about this. So I think the future remains open to give you an exact time frame. From clinical experience, patients do progress as they accumulate more metabolic complications.
Thank you very much. Professor Pavlov, why is UDCA not recommended by many authorities to be used in the NAFLD continuum?
UDCA is in general used for patients with cholestasis, and of course we have a small part of patients with NAFLD and steatosis, especially at the stage of liver cirrhosis, which was demonstrated in the Russian study. So we have a small group of patients in which we can discuss the potential use of UDCA. If you speak about the group of patients with non-alcoholic fatty liver disease in general.
Right. Thank you. Professor Schattenberg, could essential phospholipids be used in chronic hepatitis B?
Ooh, that's a good question. The way I see the essential phospholipids is something to support liver health in general. I'm not aware of antiviral activity, but if you think of it as a progressive disease, it could support. The antivirals available for hepatitis B are so potent that there is not an immediate need for this additional aspect. But if you have advanced disease, this is something you could, at an individual level, consider.
Right. A question to my colleagues, both of you. I would like to know the place of hepatoprotection in the management of chronic liver diseases in general. How do you view that, Professor Schattenberg?
Yeah, so it's a general term, and I think that best evidence comes from living metabolically healthy. So if you advise your patients on certain metabolic diets or abstinence from alcohol, you do perform hepatoprotection, which is very useful on all different types of medications. Now, is this achieved by a medication? I think this is still somewhat open to discussion. We see encouraging data in certain clinical contexts, and you have presented some of this. And I think that, yes, there's a role to propagate healthy liver living, potentially also with medications.
Professor Pavlov, what do you think about this issue?
Yes, I agree with the colleague, and of course, if you are sure that you have some influence, you are confident of pathogenesis of liver damage, that some metabolic factors interfere in this process. Of course, we have to discuss the place of some hepatoprotective agents in this group of patients. So, of course, it's hepatoprotection is adjunctive effects on the drugs which are recommended in the clinical guidelines for the moment. So we can in the clinical practice you can discuss the probably use of this kind of hepatoprotectants.
Right. Okay, Professor Schattenberg, is there a specific biomarker for the early detection of NAFLD?
So in clinical trials, I think the most sensitive tool to detect hepatic steatosis is MR. Now, that's not applicable in clinical practice. And here you have fairly good accuracy with ultrasound. Also, the cup is feasible, an imaging technique to detect hepatic steatosis. We do see emerging techniques, including metabolomics, for example, that will refine liver testing in the future. It's not ready for standard use, and it could, of course, cause incremental costs. So that remains open for discussion. But for clinical trials, we do see better biomarkers emerge. And in clinical practice, I would say ultrasound screening CAP is a refinement of this, is very useful.
Yeah, especially that ultrasound is, in fact, very much dependent on the operator who's doing the work. There are the standards that radiographists follow are very limited, and you cannot all the time accept this. But CAP, as you mentioned, have refined this very much so. And Professor Pavlov, what about the ST index in this situation?
What I must say that in general we need a very great need of tool which prognostic value on the risk of progression, especially in the patient in the group of patients with a mild steatosis, because you know that we can have hepatocellular carcinoma in this group of patients, not following the way which demonstrated to advanced fibrosis and cirrhosis and so on. And in this case, we need the non-invasive tools for evaluating the risk of progression into this complication in this group of patients. So I think that in improving our non-invasive markers, in diagnostic accuracy of these non-invasive markers, we can rely and look for a part of MRI, a part of liver biopsy, evaluating the risk of progression in this group of patients. And here, this your question about ST index is very good for screening, especially in the clinical practice of general practitioner and gastroenterologists who are not working in the special departments, who are in the clinical practice, and so that it's very good. It's very simple and very handy to rule in patients with advanced stage of disease and with at high risk of progression of fibrosis in this group of patients.
Yeah. Professor Schattenberg, is it possible that a patient of NAFLD at steatosis stage progresses to cirrhosis or cancer without going through steatohepatitis?
I think we have difficulties to define steatohepatitis in the absence of liver histology. So I would think in clinical practice, you do have patients that have fatty liver on ultrasound. They come back and they have advanced disease or a carcinoma. This can happen. I think in general, it's a slowly progressive disease. It's nothing that happens very fast. So there's a lot of time for prevention and potentially also advice, hepatoprotection of some sort. However, NAFLD does lead to cancer in a subset. It's those patients that do have inflammation. If there's no inflammation in the liver, we normally don't see a carcinoma arise. But I don't think we always catch this inflammation.
Right. Thank you very much. Well, I think we've come to the end of our meeting. Over the past hour, you've listened to a very interesting subject. Professor Schattenberg has talked about NAFLD and comorbidities and have told us about the importance of the activity of the disease and to determine how serious NASH is in any particular patient. Staging the disease and stratifying the patient needs is very important and depends on the presence of comorbidities like diabetes mellitus, hypertension, and the age of the patient. In fact, NAFLD is not only a disease of the liver, it is part of the general continuum of the metabolic syndrome. And that's why changing the nomenclature to metabolic associated fatty liver disease is probably a very wise issue. We understood that as much as the liver is damaged, we could have damages also in other organs. Cardiovascular, which may be an important cause of morbidity in these patients. Cancers, which were elegantly presented by Professor Schattenberg. The disease burden is great, and the most important thing is that no enough attention is paid to this particular disorder, probably one of the most common liver diseases at all. So we need to have more methods of surveillance and looking into the patients, screening properly, and addressing the issue in the right way. Professor Pavlov has presented to us the EPOCH study, and he has mentioned about the screening with the ST index, which appears to be interesting at the primary care physician place. However, he has also mentioned about their particular experience with EPL and metformin together in steatosis, which has shown that adding EPL to metformin has definitely improved the situation for these patients. The Manpower study has also shown that EPL can improve the situation of the liver in all comorbidities. Finally, I would like to remind you that the presence of NAFLD and diabetes mellitus is really bad news for the patient, especially if it is also associated with hypertension. I have just presented to you the most important parts of management of the disease. Don't forget lifestyle modification and exercise as important factors that must be the first pill that the patient should take. Then we have to address the comorbidities properly. We have to consider hepatoprotectors as part of the management. And when the other medications are available for us, probably we could help our patients more. Some of them are, but are very, very, very expensive. The disease can affect a large category of patients all throughout the nations. I would like to thank you very much for your attention. I would like to thank Professor Schattenberg, Professor Pavlov. I would like to thank Sanofi for hosting this program, EMJ for also presenting us, helping us in the presentation, in particular Calibrite, and his co-workers, Christy, and Also, I wouldn't forget the translators and Dorothy as well.